Bismillahirrahmanirrahim. In this third video about hyponatremia, we're going to discuss hypervolemic hyponatremia. So this is a question from the last video. If you haven't seen it before, just pause the video, and then we're going to talk about we're going to discuss the answer in the next slide. So this is a case of euglycemic DKA. The patient meets all the criteria for DKA except that the serum glucose is not really very high, as we usually, but not always, see in DKA. But he had a 9-gap acidosis, and he had symptoms of DKA, and he's diabetic, and he's taking an agent, ganagliflozin, that is known to cause euglycemic DKA. So this is one of the side effects that you need to be aware of and careful about when you have a patient on taking ganagliflozin. In hyperglycemia, we talked about that last time. The patient's serum glucose is not really very high. You expect it to be high to cause a serum sodium of 129, so that's not the case. Pseudohyponatremia usually happens with hyperthyroidistemia and a patient with multiple myeloma. There's no clues here that the patient is having any of these. I would love if they put the measured serum osmolality in the question. That would be even nicer. This question is from MixApp, but they didn't do that. But regardless, it's unlikely because there is no other features to suggest it. And then SIDH, usually urine sodium is higher than 29, as we're going to discuss in the coming videos. So usually the first step in assessing a patient with hyponatremia is to assess the volume status to see if the patient is hypovolemic, hypervolemic, or euvolemic. Now this is not always easy. I tried in this review to kind of look into the points in the history, physical examination, point of care ultrasound, and some basic labs that can help determine the volume status. And we discussed the sensitivities, the specificities of all or most of these tests. So I'm hoping that you will find it useful. Okay, so differentiating hypovolemia from hypervolemia, as I said, can be a little bit tricky, but sometimes it's really straightforward. So, for example, patient in history, the patient has cardiac disease, cirrhosis, liver disease, or kidney disease, they're more likely to develop hyponatremia due to these underlying diseases. You look for history of leg swelling, lower extremity edema, periorbital edema, or any increased weight. All this might suggest hypervolemia as a cause of hyponatremia. Examination, there's a lot of physical signs to look at. You look for features of CHF, heart failure, look for features for liver disease and kidney disease. And then point of care ultrasound also, if you have a large RBC, more than 2 centimeters, especially if it's not collapsible. If you have multiple bilateral B lines or left ventricular dysfunction, all this also suggests hypervolemia as a cause of hyponatremia. So with labs, usually, for example, in cardiac failure, AVB or ADH is increased. This might be inappropriate, and I put a question mark because it's really, we don't know exactly how to define appropriate versus inappropriate ADH. Yes, sometimes it's straightforward, but sometimes it's not. So, for example, in patient with hypovolemia, ADH excretion will be appropriate to increase the volume. We know that hypovolemia is a strong stimulator to ADH release, and we'll discuss that when we talk about SIDH. And also increased osmolality is also a big stimulus for ADH. But in heart failure, why ADH is increased? I mean, technically the patient volume is high, so why the ADH is high? Well, the body perceives the volume to be in the lower side because of the low output in case of cardiac failure, for example. So that increase in the ADH or AVB will lead to more water retention, and thus the urine osmolality will be increased, and it might be more than 200 or even more than 400. So that also can be reflected in increased urine-specific gravity. So you can look at that in a urine analysis before you do this urine osmolality test. So bottom line, ADH usually is increased in hypervolemia due to CHF. And due to cardiorenal syndrome, decreased kidney perfusion, BUN and creatinine also might be high. Uric acid might be low, low normal. In some patients with hypervolemia, that could be dilutional. But again, it can be low also in SIDH, as we will discuss later. BNB also, if it's high, it also favors the diagnosis of cardiac dysfunction or even kidney dysfunction in these patients. So all these are some lab findings that might support hypervolemia. There is no gold standard test for volume status, unfortunately. But you have to be careful with patients with hyponatremia if you're suspecting hypervolemia, because if you give these patients volume fluids, then you definitely will make things worse. So you have to be very careful. Now, urine sodium can be up or low. Really depends on the situation. Patient on chronic CHF, they might be taking diuretics, and in this case, the diuretics might be high. If the patient is not taking diuretic for some time, the urine sodium might be low again, because the body is perceiving the volume status to be in the lower side. So the ADH will be high. There will be water retention and decrease and basically anti-diuretic effect because of the high ADH. So urine sodium can be below 20, can be around 20, can be more than 40. So it really depends on the situation. So you need, again, to have a thorough clinical assessment of the patient. Okay, so a quick note about hyponatremia in heart failure. So again, due to decreased cardiac output, there will be decreased effective circulating blood volume, not maybe actual blood volume, but the effective circulating blood volume will be low despite the increase in the water in tissues and edema. And that can lead to decreased renal perfusion, and this will lead to increase in the ADH and aldosterone. And this will lead to, like we discussed before, increased urine osmolality and decreased urine sodium. But if the patient is taking diuretics, the urine sodium might be high. So hyponatremia in heart failure is actually a poor prognostic sign, unfortunately, and this has been shown in many studies. And the treatment is treatment of the underlying cause. So you usually treat congestion with diuretics and vasodilators to improve the cardiac output. And also in heart failure therapy, in addition to the salt restriction, you might need to consider water restriction if the patient is hyponatremic. Now, you don't need to do a strict fluid intake if the patient is not really hyponatremic, because fluid restriction can be difficult to follow. But if the patient is hyponatremic, it's a good idea. And then if the hyponatremia is severe and symptomatic and resistant to treatment, and again, this is usually associated with poor prognosis, unfortunately, in heart failure, but you might consider ADH antagonist, which can lead to water diuresis, and it can get rid of the excess water. For example, using tolvaptan, 15 to 30 milligram orally daily. But unfortunately, you cannot use this medication or the advice is not to give this medication for more than a month because of the side effects, especially liver dysfunction. But also you have to monitor the serum sodium very closely, and you need to allow the patient to drink water, because otherwise your patient can develop a hypernatremia really quick, and this overcorrection can lead to ODS, like we discussed in the last video. When it comes to liver disease or cirrhosis, actually it's a very similar mechanism overall. So in cirrhosis, there's systemic vasodilation and arteriovenous shunting, which will also lead to this decreased effective circulating blood volume, decreased renal perfusion, and increased sedation and aldosterone as a compensatory mechanism. And that will lead to increased urine osmolality and decreased urine sodium. But also, if the patient is taking diuretics, the urine sodium might be high. Just like in heart failure, is also generally associated with poor prognosis, and also the treatment is treatment of the underlying disease, and try to control the complication of cirrhosis and treating the ascites with diuretics and paracentesis and all that. So the relationship between the kidney disease and hyponatremia is a little bit not as robust as in cirrhosis and cardiac failure. But generally, when there's a start off a tubular dysfunction due to any disease, there will be decrease in the urine concentrating ability, and this is called hypothenuria. And now with more advanced kidney disease, there will be more decrease in the urine diluting ability, to the point that the urine osmolality will come close or even equal to the serum osmolality, and this is called isocynuria. So the urine specific gravity will be about 1.01. So this really happens usually in advanced kidney disease. And if you add to this that the patient is having more water intake, then the patient might develop hypervolemia and hyponatremia. So this really happens late in patient with advanced kidney disease, especially if they're not making much urine and they are on the stage renal disease status. Now, because of that, you have to be more cautious when interpreting urine studies, because for example, the urine light might be high just because of the kidney dysfunction, not because of the other conditions associated with it. And the association between or the prognosis and the kidney disease and hyponatremia is not well known or studied compared to the heart failure, for example. Okay, so this is the end of it. This is just a short question, and we're gonna discuss it at the beginning of the next video. Thank you.